Oh,
Just you looked at her explant?
yeah, no, that was just, she just got in touch because,
Her surgeon?
just, yeah, the people just didn't know what was going on.
Nobody seems to.
No. No.
From time to time, I'll be checking just to make sure we're still rolling and everything, but they try to ignore me. Okay, you know I have 2 of these, and I'm at a loss. Like, can you just explain maybe your short version of what happened? What has happened, and how are we in this position?
To cut a long story short, the surgeons the surgeons started using a technology called metal-on-metal hip replacement, which had been around decades ago. It was a bit unclear whether they'd done really well or really badly from the evidence that's available, but the engineers thought they could tweak a few things, just improve some quality issues and manufacturing issues and the design of them, and they tested them in the laboratory, and they found that they did extremely well when they were basically simulating a patient walking in the lab. So the whole idea was to try and reduce the amount of material or wear that was occurring with the hips. So they tested these new devices, they thought they were really low wearing, and they spoke to the surgeons, and the surgeons were very attracted by them because they wanted the best for the patients. So they wanted the lowest wearing devices possible, and they wanted the hips to be as large as possible, because people don't quite realise that when you do a hip replacement, you change something that the ball of your hip, your ball and socket joint of the hip, the ball of an average human is about 46 to about 50 millimeters in diameter ball. Now actually what you do in hip replacement classically is you remove that ball and you replace it with a much smaller, around about 28 millimeter size ball into the socket. And the problem with that is if you make the wrong movement or you bend your leg too far, then the hip can pop out or dislocate. So that was a big problem. Not a huge, yeah.
Not a
you
can
huge
change
problem.
anything if you want to like say it again.
Yeah.
That's fine too. You don't, if you need to stop and get water too.
Yeah.
Anytime.
Yeah, that wasn't a huge problem, but it's a recognised issue. And obviously, if you've got a young patient, you want the young patient not to feel like they've got a false hip. You want them to be able to do whatever they want. So those are the 2 main things. They were going to wear less, and they were going to be bigger, so they're going to be more stable, i.e. less chance of dislocating. So everything was like a win-win. The testing showed that they didn't wear, they were bigger. Surgeons wanted to use them. So everything was done surgically with the best intentions, but it unfortunately hasn't worked out.
But they weren't tested, at least in this country, I think, and correct me if I'm wrong, in humans, right? They were on machines and on simulators, but they weren't tested in human beings in human clinical trials?
Yeah, that's absolutely true. I mean, you don't necessarily need to, by law, do small studies in humans. That was generally accepted. That is what you do by international standards, was test the wear properties in a simulator. Now obviously, as you say, the simulations aren't representative of normal human gait cycles and activities. They are pretty good, but they're not truly representative. So you're not always going to pick up problems that emerge later on in vivo, in humans.
And so that's not normal. For me, I was shocked because I thought everything that was on the market and being sold and being implanted in people, like, of course it's been tested in humans. I'm not signing up for a clinical trial, or so I thought. But it turns out I kind of am part of a clinical trial.
No, I mean, I'll give you the best example I could think of is a couple of years ago in Europe. There are authorities and things like the British Standards Institute that you just have to tick some boxes to get devices put into human beings, right? And I was approached and I was asked if I could help just design a small surgical instrument that we could get into theatres, get into the operating room, see if we could get it below the belt of the authorities, shall we say, under the radar. Let's get it in there. And I was like, there's no way. don't waste my time, that's never going to happen, I just really can't be bothered with it. And they said, no, genuinely, I reckon we can do this. We can design something, we're just going to make it all up, and we're going to get it sold to a hospital. I said, no, whatever. Anyway, a month later they come back and they said, do you know what, we're not going to do that, we're actually going to, let's design a hip. Let's make up a hip, and let's see if we can get it approved for use. I was like, oh man, are you sure? So I put the time in and basically I just invented a hip replacement. I forged all the wear data, just made it up. And I didn't actually just make it up, I made it, I think it was 10 times worse than the ASR hip. Now the ASR hip at that time was under billion-dollar litigation, generally recognised to be an extremely bad hip replacement for humans. And I based the wear tests on that, but made it 10 times worse. And we basically just had to pay out, I think it was £10,000, and we would have got a CE mark, which is kind of like our regulator's approval for a device. Now you might think, oh, well, that would never happen in the United States, but in the United States there is this 510K or grandfather approval system, where all you have to really do is do some limited tests and show that your device that you're marketing now is relatively similar to one that's already on the market. Now the thing is with that, it's almost like a Chinese whispers. I don't know if you say that over in the United States. What you start off with, by the time you've whispered the same sentence to the 10th person, it's exactly the same with these products. They get less and less and less and less similar to things that were approved in some instances 20 years ago. So there's a failing of the system there quite clearly, but at the same time the people who design the products and people who are in need of new technologies, shall we say, would argue that if you overly rigorously test things and wait for clinical trials that could take 5 to 10 years, that new products will never ever, people just won't develop new technology.
But we didn't, I'm checking the focus, we didn't need a new hip, right? I mean, we didn't really need metal on metal. We had the Charnley was good, the
Charnley and then the subsequent small modification hips on that, what are classically termed metal on plastic. So the first substance refers to the ball and the second substance refers to the socket. So if it's a metal on poly, that's a metal head against a plastic liner. Now those have done extremely well, but they don't do as well in younger people. And if you're going to go doing a marathon or a triathlon, the surgeon will definitely advise against that. And there tend to be smaller heads again, so you advise not to bend your hip above 90 degrees and things like that. Again, there's an argument that those younger patients don't do as well, but actually they do pretty well. Even then, when the metal on metal technologies were introduced, younger patients were still doing pretty well. And those plastics have continued to be improved, and everything does seem to be going in the right direction. So there was a two-way approach to improving the outcomes of those patients. There was those small incremental changes to the plastics that were available, or there was okay, let's start again, let's actually go with a completely different philosophy and with this metal on metal. And unfortunately, at the start, everything looked like it was going really, really well. And you could argue actually that in certain patients, like large, healthy male young patients, that some metal on metals do very, very well.
So why are you upset about this? Like when we spoke on the phone, you had some passion about, you don't have a hip, your parents didn't get maimed by these types of hips. Like why do you care?
Well, we just saw what we saw when we examined our patients at North Tees. The metal ion levels, so the chromium cobalt levels in the bloodstream of the patients with this ASR prosthesis, in some cases was just going extremely high. And we reported our concerns to the company over and over again, and basically the product continued to be sold. That's the real issue, is companies, you can test these products and they can be put into humans and they don't perform like they did in the lab, and everything's done in good faith. But if you start to see problems and you've got good evidence being put right in front of your eyes to say that there are issues with our patients, this isn't performing like we expected it to, for a company to dismiss that data, or for a company to have more internal data that they're aware of that they aren't sharing with the researchers who are highlighting problems, that becomes into the domain of, that's not mistakes anymore, that becomes into probably calculations of loss versus profit to the company. And that definitely needs to be looked at, that definitely needs some kind of regulation. I don't think, the problem is as well is, I think the surgeons aren't aware, your general average orthopaedic surgeon is not aware of what goes on behind the scenes. And your general orthopaedic surgeon continues to be handed products that aren't performing or haven't been shown to be performing well, for example, at 5 years post-operation, but have just started using the device and everything seems to be going well. Put yourself in your position, as you know well, of those patients who received that device post-problems. They shouldn't have been exposed to those, nor should the surgeons have been given those devices without being told that actually, there's a few centres around the world that are really discovering some problems with this.
And as we're seeing in the most recent trial, in some cases the surgeons are being given bad data, like false data about, the PIN study where